Right. Let's do this. Okay. Oop, didn't know I did that. Okay. Righty doodle. Right. So just bits and bobs for those who never heard of it. This is the organization that that your organizer basically for the program today. We have ICRAM UKE, and under ICRAM UKE we have lots of clusters. So basically, it's just a non-governmental organization in UK and Ireland, again championing for as a leadership hub with lots of different clusters around it, and one of it being health and well-being cluster. Which there's lots of programs and mainly I think our group are from doctors. There's a lot of doctors in UK in this cluster, and under that we have ICRAM Medical Training Group, which is your main organizer for the program today. And they will we'll talk further about health and well-being in a bit. But anyways, there'll be more upcoming programs from us from health and well-being cluster. So just keep a close eye to it, and we have lots of things to do. Right. Anyways, just a quick update about our tentative program. So as per my screen, that's a tentative program for today. We'll try it's 2:05, but we'll give it. I'll do it as quick as possible. There'll be a bit of change in terms of our slots, just on the first slot and second slot. We just swapped the slot due to our speaker circumstances. But anyways, will be about the same thing. For slot 3, just a quick update in terms of it's not update. So slot 3 is a breakout session. So basically, it's more of an interactive session. You will be allocated to different breakout rooms. So if in your registration form you haven't sort of put any, so I think if you remember in your registration form we did mention asking what are you interested in, whether it's foundation or internship program. If you haven't sort of click on anything on that, you can always contact me. You can DM myself or our host ICRAM UKE, just so that we can allocate you to the right breakout room, because basically you're not going to go for both of the sessions. That will only be either one of the session, if that makes sense. So yeah, let us know. For those, just a quick note, for those HOs, house officers now, currently house officers, or Malaysia-based medical students, except for the new med students, who is not interested to do PLAB or don't want to do MRCP, you can always join Dr. Shafiq's session when he will explain about registration on an Irish Medical Council on completing your housemanship in Ireland. So pick your choose. If you have any changes, let us know so that we can put you in the right breakout rooms. Okay, right. A quick, that's a general FAQ. I'm not going to go further in there. Just a quick housekeeping. Again, I think you received this a day before. For those who didn't receive, I'm just going to kind of reiterate that again. During this Zoom online webinar, we're just going to try and limit the numbers of people turning on the videos and audios, just so that we don't disturb the speakers. So if you can kindly just switch off your camera and microphone at all time during the slots, unless being told so, because some of the slots will be more interactive sessions. And I think the first slot we will be needing you to turn on your video in a bit when we tell you to do so. So then we can do more of an interactive session. But otherwise, keep everything off unless you have an issue about that. And feel free to ask questions throughout the session. We might not necessarily answer it during the session or after the session. It depends on how our session is going to be. If it ended a bit earlier, we can answer during that time. If not, then we're going to go towards our Q&A session later on. That's going to be probably 10 minutes before we finish. So you can always type your questions in the chat box at all times, as you can see down on your Zoom software or apps. There's an option for you to click either everyone or personal message. So say if you want everyone to see your message, you can always personal message it to someone, either myself or to the speaker themselves, because there'll be their names there. So pick your choice in a bit, okay? And then we're gonna try and that's the SOS down there. That's during our breakout session. So if there's any issues or you're being allocated to the wrong place, you can always click for call for help. Okay, right. Fine. shall we? I'm gonna invite the first speaker. That will be Dr. Maliha. Let me turn off that one. Dr. Maliha, are you ready at any point? Perfect. All right, I'm going to turn off my video. I'll hand over the program to you. Inshallah. Bismillah.
Okay, Bismillahirrahmanirrahim. Can everybody hear me? Okay. Yeah. Dengar tak?
Dengar inshallah.
Okay, so hello, my name is Maliha Muhammad. So I'm currently IMT 2 in cardiology in Belfast. So welcome. Sorry, usually I think I haven't prepared any introduction or anything like that because my slot was supposed to be the second one. But nice to meet all of you and welcome to our webinar. So, and it is very exciting to be honest, because some of you I can see in the registration form that you guys are going to be working in the UK or in Ireland soon, or some of you are going to be working in 2 or 1 year's time. So welcome is a very good place to work in. But before I start, I think at the end of the day, a good mindset that we need to have before we start is actually having to know that medicine itself is hard and it is stressful. And I do think that some of you already work in Malaysia anyway. So sometimes you'll compare or you'll hear gossips about like news, people saying that working in the UK would be a lot more easier compared to the Malaysia. Yes, it could be. I haven't worked in the Malaysia before. I did my elective in Malaysia. I spoken to my friends who work in Malaysia. So all of us has our different struggles. So working in the UK for me is great, but don't expect that everything's gonna be just nice, easy peasy, because we also have our struggles here. But at the end of the day, so the main thing that we wanted to do in this webinar is to actually to help everybody to familiarize yourself before coming here, and then try to make it easier for you guys while working here. So working as an F1, so I can only talk in the perspective of working at the island, but in the UK. But I think the internship in Ireland would be quite similar. And then I would like, and then if not, then the other doctors from the island in this webinar can always comment and add on to what I'm going to say today. Okay, so the main thing about being an F1, so we call our HO in the UK is F1, basically the year 1 foundation doctors. So being an F1, I think the most scary part of being an F1 is the out of hours part. So being 9 to 5 jobs is you have your seniors always. You usually do a lot. We're basically doing secretary's jobs. Well, and about being out of hours, that's when you're gonna be a real doctor. It's not I'm not saying that 9 to 5 you're not being a doctor, but the out of hours you actually are need to step up your game, and then have to review sick patients, have to treat them. You have to juggle between a lot of tasks to do. So and as an F1, depends on which hospital you are in. So as an F1, being out of hours, so it's going to be from 5 to 10, 5 p.m. to 10 p.m. Or on the weekends. That's usually on the weekdays. But if it on the weekends, it's going to be from 9 to 10 p.m. For medical F1. For surgical F1, it's going to be 8 a.m. to usually 8 p.m. or 9 p.m. So that varies different hospitals, but this is usually how the templates are. And then night shift is usually again from 9 p.m. to 10 a.m. for medical, and then 8 p.m. to 8 a.m. for surgical F1. So the big hospitals, sometimes out of hours, you're gonna have maybe 1 or 2 F1, and you're gonna have your SSO, 1 SSO or 2 SSO, and you're gonna have your medical reg. But if it's surgery, usually it's gonna be 1 F1, 1 SSO, and then your reg will be sleeping at home. So that's how it's usually worked roughly. So out of hours is very scary at first for me, especially starting off in F1, because thank you, Fariha. So SSO is senior house officer. So SSO is basically MO, and registrar is basically like a specialist or a senior MO. So something like that. Feel free to type in your questions in the chat spot if you don't understand what I'm saying, basically. So, or if I'm talking too fast. Right. So basically, it is quite scary out of hours. So I think the main thing that I would like to share with you guys today is how to juggle those bleeps that you're gonna get. So in out of hours and F1, you're gonna get a bleep. So and then people gonna start to bleep. It's an on-call bleep, so people gonna start to bleep you. I think it's the same in Malaysia anyway for you to hold a bleep. So what you're gonna do? So whenever this bleep is horrendous. So you're gonna get bleep a lot of times. So believe me, myself, at one point, maybe a week after working as an F1, you're gonna try. You might want to step on the bleep, or you might want to throw the bleep in the dustbin or something like that, because the bleep's gonna go on and on and on and on, and it won't stop. So that's the stressful part of being an F1. So today I would like to share with you how to juggle between these thousands. Well, no, it's going to be thousands. It's a bit of exaggeration, but I think it's best for the best. A safe F1 is someone who knows which one, how to prioritize the bleeps. Okay, so let me share my screen. Let me see. Can everybody see that? Yeah. Okay. Um, So today my talk is basically about how to handle, or how to deal with on calls, and then how to handle different sort of bleeps. So we'll be talking about the most common things that people gonna bleep you for. So the nurses or your seniors gonna bleep you, and then these are the common things that they're gonna ask you to do, or they're gonna ask you questions about. Okay. So the main thing, how you're gonna prioritize which bleeps you're gonna do first, is by asking. You need to know what to ask. What's the right question to ask on the phone? What to say to them while you get there? And then finally, you need to rank them. You need to prioritize which one is first, which one you're going to go first. Believe me, the hospital looks small outside, but if you're working out of hours, it's become huge. So sometimes from Ward 16 to Ward 20, it takes about maybe 5 minutes or 10 minutes for you to get there. So it depends on the hospital you're in. But my hospital is huge. We have 2 buildings. So sometimes I have to run. Something I hold the cardiac arrest bleep because I'm the cardiology as a show. So sometimes it takes me about 10 minutes for me to get to an arrest call, because sometimes the hospital is very big. So it's very important for you to know which phone call that you need to go running to, and which one that can actually wait. Okay. So it's before that, is everybody okay? I don't think I can see the chat from my screen, but I hope everything's okay. Yeah. Right. So today's session is going to be a bit interactive. So I hope that people will participate with me today. So we're gonna do a bit of a role play. Okay. So instead of, because I'm sure that you guys are, some of you already work as SO anyway in Malaysia, and most of you are is better than me to manage acute stuff. So today we're just going to do a bit of a role play to practice working in the UK as an F1, trying to answer a bleep. Okay, so I'm going to be the nurse and you're going to be the F1. And we'll go through the 3 bleeps here in the first exercise. And then after we go through all the bleeps, I would like you to rank the bleeps. So which one you're going to go attend to first. Okay, so in the role play, I'm gonna be the nurse. You're gonna be the F1. So what I would like you to do is I would like you to know to try to ask me questions, relevant questions, and I would like you to say to me what I'm gonna do while I'm waiting for you. And then after that, after doing all of that, we're finally gonna rank which one that you need to go first. Okay. Let me see. Hold on, I'm gonna try to see the chat. Okay. Let me see. Can anyone tell me how to open the chat room while I'm sharing my screen? Here, okay. Oh, there. Okay. All right. So, okay. Pajam. Okay, so does anyone want to volunteer to be the F1 for the first exercise, please? Anyone? No? Can I pick someone? Yeah. I'll just pick someone. Can I pick someone? Am I allowed to do that? I'll just pick someone. Let me see. Amma Wahab? Are you there, Amma Wahab? Mr. Amma? Okay, sure. Thank you, Amma. Can you open your video and unmute your video, please?
Sorry, my video is a bit weird.
Okay, it's fine. Right. So I'll be the nurse, okay, and you'll be the F1. All right.
Right.
So we'll start. So bleep bleep. Hello, my name is Molly. I'm one of the nurse in ward 16. I got a patient here with a news of 4, and he got a temperature of 38.8. Can you come and review, please?
Right. Can you tell me a bit more about what's happening?
Right. So the news of 4, and he got a temperature. Yeah.
Okay. What's going on with him?
I don't know. He looks a bit restless. He's now on the he's now on the bed. He's a bit annoying at the moment. He's saying that everything is hot, and then I've already given him the paracetamol, but he just can't sit still. I'm very worried.
Right.
Can you just come?
Right. So does he appear confused or anything?
No, he's not.
He's not. Have you given him anything else?
Sorry?
Have you given him anything else?
No, I only give him the paracetamol.
Right. So okay. Can you tell me the vital signs, please? What's going on? Can you tell me the vital signs, please?
Oh, yes. So the blood pressure is 102/90, and the heart rate is 75. The respiratory rate is 10. What else? The sats are 98%, and he's not on any in any oxygen.
Okay. He seems quite fine. I'll respond when I have the time. Okay.
Are you gonna come now?
No, not yet. I have other things to do.
Okay. So
yeah.
Shall I just wait?
Yeah. So you continue and monitor him. I'll come for him in a bit when I have the time. Okay.
Okay. So I just watch him then.
Okay.
Thank you.
Yeah. So.
Okay, that's fine. Thank you, Amma. So that's how you're gonna do it anyway. So what do you think about this case?
This case?
Yeah.
Well, the new score is 4. Which is.
Have you worked in? Sorry, what's your? Are you already working as a special?
No, I'm a medical student, final year.
Okay, very good. And then
So,
where about do you study? Is it in the UK?
No, in Malaysia, but under Newcastle University.
So do you know? But I don't know. Do Malaysia use news?
Malaysia don't, but our uni does.
So can you explain a bit about news to the rest of the audience, if you don't mind?
So the news score is, I think, as said in the chat, is a national early warning score. So it's essentially basically a compilation of vital signs, like BP, temperature, and whatnot. And based on that, it scores basically how ill the patient is. Although it can be at times quite tricky to determine what is bad and what is good. Because which personally I do have a difficulty understanding still. But it seems from this patient that there's no particularly worrying, I mean, to me anyways, vital signs in terms of each parameter seems okay. Nothing is particularly, it's slightly worrying, but not crazily worrying. So that's why I decided, to hold it off for now. Moving on to tasks. Yeah.
Okay. Thank you, Amma. Right. So thank you for participating. So yeah, that's very good. So basically, that's basically things that you need to ask. So when it comes to temperature, 38.8. So the most crucial thing that we would be worried about, could it be sepsis or could the patient be sick? So I think you did ask the right questions. So when it comes to news, so news is basically vital signs. So it's a score that the nurses add up on the observation chart. And then the higher the score, it means the more acutely unwell the patient is. So that's basically it. But at the end of the day, the new scoring system that we use in the UK is not perfect. And so we're trying to, so the different hospitals sometimes use different news score because it's not perfect. As I say, sometimes the news could be high, but the patient could just be fine. So don't always depend on the news. So if the nurse say to you, the news are 4, so I think the main thing that you need to ask them, yes, why are the news are 4? Tell me, what are the vital signs? Because number 4 doesn't mean anything. So the main thing is you need to know what are the vital signs. So in these patients, that the patient only doesn't really met the septic criteria because as you see the sepsis, the septic criteria, you need 2 out of 4 to score to say that they're septic, but the patients still have a high temperature. So things that you need to ask on the phone to allow to helps you to make your decision whether this is acutely unwell patient is simple things like what are the news, what are the vital signs, how is the patient, do the patient look sick to you, nurse, and then you need to ask them, so tell me a bit of basic stuff about the patient. Why is the patient inside the hospital? So is the patient, because sometimes the patient is already on antibiotics because the patient's in because of sepsis anyway. That's why they're spiking temperature. So it's not really quite surprising that the patient is spiking temperature because they're here because they're septic and they're already on antibiotics anyway. Okay, so ask them, why are the patient in the hospital? Why are they admitted with? Okay, and then after that, so you don't have to go. You don't have to be lengthy. Just ask them things that just helps. Just it's enough for you to make your decision whether this patient is sick or not. And then after that, things that you can say to them is, obviously with a patient with spiking temperature, you need blood cultures. So it's just say to them, can anyone take bloods? Can anyone take bloods? Can you please take blood cultures for me? And then I'll come to review them whenever I can. So just say it like that. But obviously, different hospitals different. Sometimes the nurses can take blood, and sometimes the nurses can't take blood. So if the nurses say to you, "Oh no, we're not trained to take blood," well, some usually most of them would say that to you, "We're not trained to take blood." So you just say back to them, "Oh, that's fine then. Can you just prepare the equipments for me? So whenever I'm there, I'll take the blood for you." So at least you can say to them what they can do while waiting for you, and then they just say to them, and just reassure the nurse, because the nurses are the one that are going to go and reassure the patient. So just reassure the nurse. So Molly, the patient doesn't sound acutely unwell, but again, I acknowledge that the patients have temperature. So the right thing to do first is to take blood cultures and to take bloods, to send off bloods. So can you do that? If you can't, can you prepare the equipments? And I'll be there to do that, and I'll review the patients later. So that's the main thing when it comes to trying to reassure the nurse, so that the nurse can then go and reassure the patients and tell them, yes, the doctors are on the way, but the doctor did tell me that we're going to do blood cultures, blah, 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 to the patients. Okay, so, and then I think that's basically it for a temperature spike. Do you guys have any questions? No? Well, I can't see the chat room anymore. Let's see. Where is the chat? Oh yeah, there they are. Okay. Yeah. Oh no. So the nurses, well, don't ask too much questions. But I think if you ask the relevant questions, the nurses should not be annoyed because the questions helps you. Because if the questions helps you to get there quicker, but obviously there are certain nurses that will be annoyed if you ask too much, and it'll be like, that's why sometimes they'll be like, just come, but you just explain to them nicely, say to them, I'm sorry, but I need to know, I need to know these things because it helps me to decide whether I need to go to you first or I need to go to what 20 first. So things like that. But I think the nurses, mostly the nurses in the UK, are very good anyway, even in Malaysia. So I think it depends on individuals. Sometimes they're not good, they're very impatient, but you just need to try to explain to them why you're asking these questions. Okay, any more questions? If not, we're going to try to move on to the next one. Right. Any volunteers? Shall I pick? And Shade Zeman, please.
Yes, hello.
Okay, hello, thank you.
Yeah.
Shall we do the second one here?
Yeah, by the way, my name is Syed Ziman. I'm from Malaysia, currently doing housemanship. Yep.
So you should be fine then. Right, so we'll do the second bleep. So bleep, bleep. Hello, my name is Callie. I'm one of the nurse in ward 3. So I'm so annoyed. The patients in the ward is asking for a sleeping tablet. It's getting a bit annoying. So can you just please come right now and prescribe the sleeping tablet, please?
Okay. Yes, sure. But before that, can I just ask regarding the patient? Is the patient well, or is he or she becoming aggressive?
No, he's fine. He's just sitting there on the bed.
Okay, all right. By the way, I have to attend some other acute patients. So if you can give me a few minutes, probably I'll drop by.
Okay, that's fine.
Yeah. Okay, thank you.
Okay, thank you. Right, so what do you think about this case?
Well, I think zopiclone is a non-benzodiazepine. It is used for sleeping pills, of course. Well, probably patient has some sort of insomnia. Yeah, so it is not urgent, I presume. So is in the situation whereby I am in the midst of attending acutely ill patient, so I should prioritize this as probably at the bottom. Whenever I'm free, whenever the patient of the acutely patient has been stabilized, then I would probably attend to this patient.
True. Yeah. So what are the things that you think you should ask the nurse? And then you did very well because you asked them how is the patient. So if the patient is not being aggressive anyway, so what else do you think that you should ask quickly?
Probably I should ask the vitals. Probably I am not so sure about that. Yeah.
Yeah, you usually a quick way in the UK to ask for vitals. You just ask, how's the news, and it'll be like, oh, the news are 0. So you'll be like, oh, okay, so that's fine. He's fine. So that's it. So I think that this one is quite simple. And then what do you think? And then what are the situations in which whenever you get there, what are the things that makes you have second thoughts about prescribing zopiclone?
Probably I would say that if he or she really requires zopiclone, I would probably assess whether is there a need to prescribe that medication.
And how do you assess that?
I'm not so sure about that. Yeah.
Okay, that's fine. Thank you
Yeah.
so much, Shade.
No problem.
So that's lovely. So I think you know your stuff anyway because you already work as an SHO anyway. So when it comes to Zopiclone, I think things that you need to take that you need to ponder about is, for example, does the patient take Zopiclone regularly anyway at home? And then so you basically go and check the Cardex. So check the Cardex. Sometimes they already are on Zopiclone, and the day team actually had hold the Zopiclone because of something else. So you can't just go on and be like, oh, I'll just prescribe Zopiclone. There you go. But then suddenly the day team be like, oh my gosh, we just thought the Zopiclone, but the night F1 just prescribe it again. And then they'll be like, suka hati. So check first in the Cardex and the notes, what is the patient's already on Zopiclone, and why did the day team stop the Zopiclone? Second thing is check whether the patients have any mental health problems, because obviously the Zopiclone can interact with the other mental health drugs. Okay, so things like that you need to check. And otherwise, if everything is fine, you can just go ahead and prescribe the Zopiclone. But in my experience, to be honest, if the patient's news are 0, this is quite bad. But to be honest, I would usually delay. I would walk very, very slow, very slow to the ward, because by the time I get there, the patient is nicely sleeping. So sometimes they don't really need them. But then at the end of the day, if you just, so I think at the end of the day, you just need to review them properly. You can't just go. I am quite tempted later on as a stage finishing F1, I would very tempted to just go there and be like, yep, Zopiclone, yep, Zopiclone. But end of the day, I think it's just better for you to check whether they have any mental health problems, whether they're already on Zopiclone, and then try to check interactions with other drugs. Okay. Thank you, Shade. So the next one, anyone want to try to the next one? Maybe the last one?
Miley, just a quick reminder, 10 minutes to go.
Yep. So we'll do the last one. So I think I'll do I think I'll just explain about the last one. So the last one, the news are 6 and sets are 97% and 2-liter tachycardic heart rate 120. So these are example of a bleep in which the nurses will be freaking out and be like, oh my gosh, the news are 6. And so I think the things that you need to ponder about here is this oxygen saturation is quite low and the patient's on 2 liters of oxygen and the patient is tachycardic. So first thing that you need to say to them, so I'll just be the F1. So, okay, so can you tell me about the rest of the news? Blah, blah, blah. So the only thing that I'm worried about now is the sets are on 2 liters. So you need to ask them, so is this, are they on oxygen anyway before? And then they'll be like, oh no, they were not on oxygen before. And then you need to ask, so tell me about the basic, why are the patients in? Does the patient have any chest infection, stuff like that, basic thing to ask. And then after that, you need to, and then you just say to them, I'll be there as soon as I can. But in the meanwhile, while waiting for me, can you please do an ECG as soon as you can? And I'll be there and then I'll assess the patient as quick as I can. So obviously there are the things that, this is an example of a bleep that you can't just ignore and then just try your best to go to this patient first. Okay, so that's all common bleeps that you get. So does anyone want to type on the chat room the order? Try to rank the bleeps. What do you guys think? Which one will you go first? Okay, so yeah, so 3, 1, 2. So we'll go back to there and let me see. Yeah, so 3, 1, 2. Yeah, I would definitely go in that order, to be honest. And by the time you get to bleep 2, trust me, usually they'll be sound asleep by the time you get there. Okay. So yeah, so that's how you rank the bleep. So I actually have 2 more exercises, but we'll skip that because we are running out of time. So I think you'll get, I can email people this slide if you want, and you can ask me questions by email if you want, okay? So that's that's the most common bleeps that you're gonna get. So I'll show you a bit of a preview of things that you're gonna get. So things, for example, that you're gonna get is the nurses will ask you to review ECG, people complaining of chest pain. So the chest pain, please don't ignore the chest pain, okay? So All right. So now we'll go to the next part, which is don't be afraid. So I think as an F1, you have the privilege of asking for help. So don't think that you need to deal with things by yourself. The SSUs are there, the regis are there. So do not feel afraid to call for help. Try, and then I think at the end of the day, the most important, so you can be the most brilliant F1 as you can. But I think in my opinion, a good F1 is a safe F1. So you know when to, you know your limits, and you know when to ask for senior help. Okay, so ask for help. So today and then I think there's an art, or how we say it in Malay, ada seni to ask for help. And then so sometimes your SSO or your reg are very grumpy. So I think it's best for you before starting tour as an F1. So this is what I learned the harsh way, because I didn't know how to ask for help on the phone. So I think the main thing to do is you need to learn or practice how to ask for help, how to talk on the phone, to talk to your reg or to your SSO about an acutely unwell patient, so that they will then know what advice to give, and then they will then know whether they should be running there to help you, or they can just give instructions to you on the phone. Okay, right. So we'll start here. So so you can use S bar. So I don't know whether you guys use S bar, but I think the medical students in the UK usually use S bar anyway. It's a system to do the handover. But at the end of the day, you can just devise your own way or system on how to talk on the phone to your senior. Okay, so this is my way, to be honest. So I would usually go, hi, my name is Molly. I'm one of the medical F1. Can I discuss a patient on Ward 16 with you, please? So the story is Mr. Bobo, a 65-year-old gentleman. So he came in with a chest infection. He was admitted 2 days ago, and he's on antibiotics. In terms of past medical history, he got hypertension, he got previous clot, but otherwise he's fine. I got his cardex in front of me here, so I can see that he's on antibiotics. It's day 4, and he's on blah blah blah. So I've examined him, blah blah blah. His news are 0. And then if it's important, just mention about the input and output, but if not, it's fine. Or you can just say his euvolemic is he's fine. And then what I've done is I've taken the blood, I've sent off a urine dip, I ordered a chest X-ray. I'm quite worried. I'm not worried, to be honest, but I just want to check with you. Do I need to do anything else? Can you advise me to do anything else? I don't need you to come here running, but I just want to know what else do I need to do, or am I doing the right thing? Okay, so that's how I usually do it, right? Anyway, but obviously in real life, it changes, it varies differently. If there's an acutely unwell patient, I would just go, hey, it's Molly. I'm in Ward 16. Mr. Bobo, a 65-year-old gentleman, he has a chest infection, and at the moment his news are 10. I'm very worried. I'll try my best to go and assess the patient at the moment, but can you just please come right now? So if it's a acutely unwell patient, you don't have to go through everything. So it depends on different situations. But I think if the patient is not acutely unwell, you can just go through the system, because your senior or your SSO or your reg needs to know what's going on, because they're busy themselves, so they can just come running to you whenever they can. Okay. Right. So we'll do practice. So this is the last session anyway. So we'll do the practice. So can I ask for a volunteer? Let me see. Can we go Shafika? Shafika?
Yes, 1 second.
Sorry. Thank you.
Hello.
Okay, hello. Nice to meet you, Shafika. Can you please introduce yourself a bit?
All right. My name is Shafika Amanda. I'm a final year medical student.
Okay, so what we're going to do, Shafika, is we're going to practice on how you're going to ask for help. So I'll give you a slide here. So everybody and yourself can just read on through, okay? So this is a case. So the nurse will be calling you that, hey, doctor, my patient has not passed urine for the past 6 hours. Can you come review? So so imagine that you already went and reviewed the patient, and these are the impressions that you got after you do all your examinations, after you do all your A, B, C, D, E. So these are the things that you got. So these are, and then you've checked the notes, you've checked the cardex, and these are the informations that you got. Okay, and we'll go through it after that. In the meantime, if anybody got any questions, please do. Just tell me whenever you're ready. We'll try to do it in maybe 20 seconds.
Okay, I'll try.
Okay.
Okay. Sorry, who am I calling?
So you're gonna call your SHO.
Oh, okay.
There's a bit of a dengung sikit.
Oh, is it? Is this one?
Okay, take your time.
Yeah. Okay. Okay, right. Hello. Is this the medical SHO?
Yeah.
Yeah. Hello. Hi. My name is Shabka. I'm one of the junior doctors in the ward. So I've got this 80-year-old gentleman with me. Is it okay if I review him with you?
Yeah, it's fine.
Yeah. Okay. So this gentleman, he was admitted with a fall and a community-acquired pneumonia. So he's been in the ward for a few days, I think. So he was planned to right. So I'm a bit worried about him because he's currently has hypotension and he hasn't passed urine in 6 hours. So I'm worried this might be an AKI. So I just need some help with him. Yeah.
Okay. So what have you done?
Right. So he's currently on medication for his pneumonia. He's on he's on antibiotics already, and so I checked his catheter, and it's flushing well, and there was no clots. But yeah, I checked his BP again, and it's still quite low. And previously it was 140/80, but now it's 101/70.
Okay.
Yeah, and I've done some investigations. I've done a bladder scan, and currently there's 110 mils in the bladder, and other than that, his
has he got any?
fine.
Yeah.
Yeah, and his creatinine and EGFR is dropping. But yeah, and his urine dip is clear.
Okay.
Yeah.
You did very well, Shafika. So I think so. Do you want me to come right now? Are you okay doing by yourself, or do you want me to come now?
Yes, please. Can you come down and view him?
Okay. So I'll try my best. I'm just drinking coffee at the moment. I can come.
Okay.
So
Thank you.
yeah, that's very good. So I don't do this. So it's just a bit of a practice, but then the SHO usually be like, okay, what have you done? So you'll be like, oh, I've taken the bloods. And so usually the SHO will be like, okay, that's fine. So that's the most recent UNE that you've done. So just repeat the bloods again. You did well with the urine dip, but just send off MSSU because sometimes urine dip is not that clear anyway. Okay. And then they'll be like, and then they will ask you about the urine input and output, which is as you said before, and then usually they'll be like, okay, that's fine, I can come at the moment. But if the patient, if the SHOs are busy, don't feel so. That's why I asked you again, do you want me to come? So usually don't be afraid because you're the F1 and then they're the SHO or the reg, so it's their duty to go and help you. So you've done all that you can, so that's all that you can. So I think if there's nothing more that you can do, then just say to them, I've done these are the things that I've done, so please come And because I think I can't handle this by myself. Don't be afraid to say it to them. Don't think that if you say that to them, they'll think that, oh, this F1 is no good lah. This F1 boleh balik kampung kan. But no, you just say to them, you know, I this is out of my hand. Can you please come and help me and review and tell me what I've done right or what I've done wrong? And this is very important because even though you know you're doing the right thing, there's nothing else that you can do. It's just best for the SHA to come and they'll show you how to review patients and you can just compare, you can just learn. Oh, I didn't do that. Oh yes, I did do that. So it's your learning anyway. So don't feel afraid lah to call them. So in this case anyway, so these are the things that these are the informations that you need to have before you call your senior. Okay, but as I said, it depends on the situation. If the patient is unresponsive, if you think the patient's blood pressure is very, very low, then you can just go ahead and be on the phone. Hey, Molly, I don't have any information. I usually do this to my reg. Anyway, hey, Dr. Wafi is the reg. Hey, Dr. Wafi, I don't have a patient's very sick. I don't have any information on them. I haven't examined them. I can't tell you anything. Just come. So if the patients are very sick, just say that to them. But otherwise, you can just go and properly read on the notes, look at the cardex, examine them, look at and then have everything in front of you at the phone. So have your cardex, have your news chart, observation chart, have your input and output, and then call, and then have the notes in front of you, and just call the SHO or the reg. In my experience, it's very annoying if they'll be like, oh, hey, Molly, the F1. So, oh, hey, so what's the problem? Oh, I'm not really sure. I think the patient hasn't passed any urine. Like, okay, so what's the input and output? Oh, hold on. I'll go get the fluid balance chart. And then they put on the phone. And then 10 minutes later, they come back. Oh, the input, output, and this. And I'll be like, oh, so what medications are they on? Oh, hold on. And another 10 minutes, and they'll come back to the phone. So have everything ready on the phone so that you can help. Okay, so thank you so much, Shafika. So I think that's it basically. So there's a couple of things that I want to say, but obviously we're running out of time. So in terms of management in this case, try a fluid bolus because obviously the patient's having a mild AKI. The catheter is working anyway, so it's not an obstructive condition. So it must be either renal or pre-renal. So it's not post-renal. So try a fluid bolus and then try to stop any nephrotoxic. And then try to repeat the UNE and then be cautious about fluid because you need to make sure that the ejection fraction or they don't have any heart failure because sometimes you can actually overload them instead of helping them. Okay, so that's basically how the case usually goes. So as a conclusion, for me to close my slot, there's actually is no right or wrong answer. So as long as you be safe. So there's a couple of exercise that adapt. The second exercise is actually there's no right or wrong answer. You can actually, because at the end of the day, medicine is not black and white. There's always a gray part of it. So there's no right or wrong answer. As long as you're being the safe at one, as long as you already call your senior, you've tried your best. So there's no fret. You've tried, you did your best. You can't be at the same place at the same time. You can't be at two places at the same time. So don't worry if you can't get to a sick patient. If you're dealing with another sick patient, call your SHO and say to them, hey, I'm dealing with a sick patient. Can you go to the other one? Okay, so ask for help. And then you will learn your reasoning or prioritization with time and experience. So don't be worrying about that. You just need to know what's the right questions to ask. And you need to know what to say to them while waiting for you. And then you need to reassure the nurse. If you don't reassure the nurse, believe me, they'll keep bleeping you again and again and again. And finally, just ask for help, okay? Because you're the F1, so it's a period for you to learn. So just ask for help, okay? So I think that's basically it. Thank you so much for the time. Sorry that I'm running a bit late. Thank you.
All right, thank you so much, Dr. Maliha. Right, so that's basically a typical, I think, generally how foundation year trainees doing their ATSP, or we call it asked to see patients. Whenever you've been asked to see someone in the ward, whether urgently or not urgently, it's basically a general approach. You just use the same framework, and that's what we use. We're going to share you the slides, so don't worry about it. If you have taken notes, that's good, that's perfect. But we'll share you the slides later on. Right, we're gonna proceed with the next one. So just bear in mind, we're just gonna run a few minutes late as we go. So we'll see how it goes if we can compensate with some of the slots. Second session will be a slot 2, which means we're going to talk about outline of a typical day. Basically, a typical day as a doctor, basically, whether you're a houseman, a senior house officers in the ward. And we're going to have 2 of our lovely doctors, that will be Dr. Shahira and Dr. Fariha, which is going to share you a bit and bobs of how things work basically in ward, mainly in a UK and Ireland kind of setting. It might be the same as Malaysia, may not be the same. Just bear in mind, this is something that we do often every day. So we can kind of don't compare much with the Malaysia, how Malaysia works. It's a bit different. It might be different, might not be different. We'll see how it goes. Right. Can I please invite Dr. Shahira if you're in here? If you can turn it, there you go.
Yes, I'm here. Hello, hi.
And hear clear, crystal clear. So I'll hand it over to you. And then yeah, please go on.
Right, okay. Hi everyone, my name is Shahira. I'm currently an FY1 in Cumbria, UK at the moment. I'm going to give you a talk on how a ward round normally runs. I'm trying to figure out how to share my screen. Don't really know how to.
There's a button down there, share screen.
I've clicked the share screen and it gives me a bunch of options.
Yeah, click the desk, the tab that you're gonna share.
So desktop. Okay, one sec. I'm so sorry. Isn't really. One sec, I'm just trying to bring it up. Okay, can you guys see my screen now?
There you go. Yep. If you open up your slides.
Presentation, yeah. It's coming up. Bear with me a second. Yeah, so the way I'm going to do this is I'm going to break it down into 3 parts, which is before the ward round, during the ward round, and after the ward round. So before the ward round, right, so I come into the hospital at 9 a.m. or 8 a.m. depending on whether I'm on a surgical rotation or medical rotation. I grab my pen, take my coat off, put my bags aside, grab a pen, grab my stethoscope, and grab a blank piece of paper. And then the first thing I would do is I grab a laptop, and I would choose the one with full battery, because it's really annoying when your laptop dies in the middle of the ward round, because you're going to spend 7 minutes trying to find another laptop that works. And I normally have my favorite laptop that I know works very well for me. So it's important. So it'll be different. So I should probably preface this with the fact that what works for me might not work for you. There's no hard and fast rule. I'm just sharing with you the things that I find work well with me. So you'll find your own style once you start working, but these are the things I find useful for me, might be useful for you, might not be. But yeah, everything I say, take it with a pinch of salt. Okay, so yeah, I grab a laptop. I grab my favorite laptop, the one with full battery, and then I would log into the systems that I know that I need during the ward round. So the system that I use in my hospital is Lorenzo. That's a system that we use to find our patients and also document the ward rounds. And then I will also log into PACS, because sometimes my consultants and my seniors, they like to look at the actual images. They don't really trust the reports. And sometimes, x-rays, they don't always get reported. So especially like orthopedic surgeons, they like to look at the actual images, whether it's x-rays or CTs or whatever. So yeah, I log into PACS so that we can actually see the images and not just the reports. And then because in my hospital, most of the things are electronic, including the patient's ops and news chart. So those things go into this thingy called e-outcome. So I would log into e-outcome as well, because that will give me the patient's ops. So at that point, I would have logged into the system already. And the next thing I would need is a list of my patients. So as an FI1, you need to know where this list exists. Speak to your seniors, ask them which folder. Sometimes it's not in a laptop, sometimes it's on a desktop. So you need to log into a desktop first, which is attached to a printer, so that you may be able to print the list. So yeah, know where to get this list and know how to get access to this list. You might need to speak to your line manager, speak to your seniors, speak to IT, whoever, just find out a way to get this list. Then once you've got access to this list, print the list. So the list usually has a list of existing patients. You also, at this point, I would also want to know if I've got any new patients under my consultant's name. So new patients, they can be new admissions that were admitted either yesterday or overnight. So these patients usually, if they're admitted overnight, they might not have been post-taken by any consultant yet. So post-take means they are being seen by a consultant, whether medical or surgical, for the very first time in hospital. And it's a big thing because they would come out with that proper management plan for the patient. So if they have not been post-taken by any consultants, then you need to do a post-take ward round with my consultant. So I would have to go through the full history, what investigations have been done during the admission, what were the results, and what has been done in terms of management. Have they started antibiotics? Are there any pending investigations that I need to chase, any results that I need to chase, etc. So yeah, so that can be new patients, new admissions from the day before or overnight. And new patients can also be transferred from a different ward. They can be stepped down from ICU or HDU. So I need to find out what have they been admitted for, what have they been treated for, what have they done in those wards, and what are the current outstanding issues. So yeah, those are the new patients. And as for the existing patients, normally at this point, I would go up to the nurse in charge on the ward and ask the nurse in charge, did anything happen overnight? Did any patient fall ill? Did any patient have a fall on the ward? Did anyone from the on-call team review any of our patients? Did they do any investigations? Do I need to chase any pending investigations or any results? If any of my patients had operations the day before, I would go through their op notes to see if there are any specific instructions post-op. And also existing patients, don't forget the outliers, because sometimes, you know, when you're based on a ward, most of your patients are there, but you might also have patients on other wards that are under joint care between medical and surgical teams, for example. So yeah, and also because our news charts are now electronic, I would look on the e-outcome thingy that I was telling you about, and I would look at the latest ops. And so it's important to, all these values that you get, the vital signs, do not take them at face value. Always look at the patient's baseline. So look at the trend. If the PB is low, has it always been low? Is that normal for the patient? Is that her baseline? Or did it drop suddenly from 150 systolic to 90 systolic? Do you know what I mean? And let's say if a patient I know had a bit of a temperature yesterday, I want to know, has the patient had any more temperature spikes? Has the patient been persistently paraxial, or has that settled? You know, things like that. So these are the things that I look for before I start a ward round. So yeah, and then the consultant's ready for ward round, get the ward round started. So what I need during a ward round is the list that I've already printed. I would need a pen, I would need a working laptop, like I said, I would need my stethoscope, and I would need a blank piece of paper where I would jot down the jobs generated from the ward round. And also, depending on, you know, some consultants have got their own ways of doing ward rounds. Some surgical consultants, they would like me to carry a box of gloves so that they can easily change gloves between each patient that they see. And also, I would carry a few add-on blood forms, because sometimes, you know, you take patients have had FBC, renal profile, and CRP taken, and then you found out during ward round that they've got slightly low potassium. You'd want to check their magnesium, so you can add that on to the blood form and just send it off to the lab instead of taking more blood for the magnesium. And depending on hospitals as well, in my hospital, we do referrals between specialties using a paper. So I would take some paper referral forms, because in case any of our patients needs to be referred to another specialty, I can quickly do it during the ward round. And then during the ward round, my job as an FI1 is basically, so in this case, I'm doing a ward round with a consultant. So my job, when there's a consultant around, my job is just to document what's happening during the ward round. So what I do is I multitask, basically. I try to listen to what's being said by the consultant and by the patient, and I'm also trying to type at the same time, and I'm also trying to look through every single other thing at the same time. It's difficult at first, but with time and with lots of practice, when you do this day in, day out, it will become easier and it will become second nature to you. So yeah, it's important to document well. But I know it takes a lot of practice, and yeah, I mean, documentation can be a legal thing, so it's important to document well. So, and also during the ward round, it's important to acknowledge any significant events. Like I said, if the nurse told you, oh, the patient had a bit of a temperature last night, was a bit tachycardic, was septic last night, had to be reviewed by the on-call team, you need to acknowledge that. Sometimes the consultants don't know, so you need to tell the consultant, oh, this is what happened to the patient overnight. They started antibiotics, or they've stepped up the antibiotics to something stronger, or whatever. Or has the patient been reviewed by another team yesterday? Maybe you referred to the patient to a different specialty yesterday, and they have been reviewed. So you need to tell the consultant, oh, the surgical team has seen the patient, they don't think it's anything surgical, blah, blah, blah. So it's important to tell your consultant that that's happened. And it's also important to document that you've seen their review and you've noted the input, many things like that. And important to know if any scans have been reported. You know, sometimes MRIs, they take a bit of time before they can get reported, things like that. And you also need to review investigations results. So like blood scans and sometimes blood cultures. Sometimes we forget that patient was paraxial 2 days ago and blood cultures were taken. It takes 48 hours before it can grow anything. So it's important to always review. Remember, oh, a patient had blood cultures 2 days ago, it's time to check. Blood cultures, urine cultures, stool culture, literally anything. Yeah. And also don't forget to review what medications the patient's on. Are they on VTE prophylaxis? Should they be on treatment dose Clexane? If they're on antibiotics, you need to make sure that you know what the indication for the antibiotic. Is it still indicated first? Number two, is it the right route? Is the patient on IV? Can it be stepped down to oral now, or should we continue with IV for another 48 hours or so? And let's say the patient has come in with exacerbation of COPD and they've been treated with nebulizers. If you want to send them home, you want to wean them off nebulizers for at least 48 hours. You can't be on nebulizers today and send them and get home tomorrow. Yeah, you need to wean them off first. So should we start weaning off today, or do we do that tomorrow? If the patient's on IV fluids, is it the right IV fluids? Is it the right rate? Is it quick enough? How quickly do you want to give it? And is the patient in pain? Is the pain under control? Do you need to review the analgesia, etc.? So yeah, review the whole prescriptions. And let's say the patient's in AKI and their nephrotoxics have been withheld. So you want to check if their renal function is now back to baseline. Should we reinstate the omitted nephrotoxics, or should we just carry on withholding the nephrotoxics? Yeah, and like I said, most of the things in my hospital are electronic now, but there are still some things that are, the charts are physical by the bedside, like the fluid balance, the stool chart, the daily weights. So it's important to, you know, review all these things just so you're not missing anything out. And it's important, right? So this is quite like specialty niche thing. So it's important to clarify the status of the patient. If the patient is under surgery, for example, is the patient nail by mouth? Is the patient nail by mouth going to theatre today, or is the patient nail by mouth because they're on drip and suck management for bowel obstruction, or is the patient nail by mouth for a scan that's going to happen today? And if the patient is under orthopedics for a fracture, has had some fixation in theatre, is the patient okay to weight bear today? Is it full weight bearing? Is it toe touch weight bearing? So just clarify these with your seniors during the ward round, and it's important that you document these as well on the ward round. And let's say the patient has had stroke, what level of fluids are they on? Are they on thickened fluids, or are they completely nail by mouth? Do they need review by the SALT team, which is the speech and language therapist team, right? And also, you need to know what are the issues keeping the patients in, because when the patient is in hospital, the key question that you want to ask yourself is, can we discharge this patient? If not, why not? Are they medically fit for discharge, but they're just waiting for social arrangement to go home? Or are they medically fit for discharge? Are they medically fit for discharge, but they're just needing a bit more work with physio or occupational therapists to get back their mobility and functional status back to baseline? What you need to clarify that, you need to document that so that it's easy. It's good practice to do that. And also during the ward round, write down all the jobs generated during the ward round, regardless of how small the job is. Because if you don't write them down, you can forget the jobs, and that can prove to be a problem later on during the day or for the on-call team. Yeah, and also when you are coming up, so ideally, sometimes, you know, a patient is being treated for chest infection on antibiotics, recovering well. And that's ideally what we want to happen. But it's also important to remember that we need to always anticipate the worst. So we hope for the best for the patient, but we also need to prepare for the worst. So in the event of deterioration, is this patient to be escalated to HDU or ICU, or are they just for ward level care? So it's important to clarify this with the consultant, and just document that very clearly, so that in case the patient gets reviewed, in case the patient deteriorates overnight and the on-call team reviews, they know, oh, the patient is to stay on ward level. They will not go to HDU for CPAP or whatever. Do you know what I mean? And if they've got a DNAR status in place, document that as well. So yeah, I've included here like 3 examples of ward round documentation for you to go on during your own time. And I've noticed that from our preliminary survey that one of the concerns by you guys is that you guys want more support in terms of requesting scans. So what I tend to do is I tend to request scans during the ward round itself and not after, just because I've got the consultants and my seniors next to me, and I can clarify with them why exactly are we doing this scan. So when you're requesting scan, you're basically communicating with the consultant radiologist that you're trying to convince them that this patient needs this imaging to further aid in their management. So what they would want to know, they'd want to know the relevant background, they want to know the relevant symptoms, they want to know the relevant examination findings, they want to know the relevant investigations. And the most important thing is that, what is your clinical question? So if you are unsure, don't hesitate to ask your consultant. Just stop them in the middle of the ward round and be like, excuse me, can you just repeat why we need to do the scan? Do you know what I mean? Yeah. So even if it puts a pause to the ward round, it's important to just clarify why the scan is needed, rather than risk having the scan rejected later on during the day. Because if the scan gets rejected, sometimes you don't realize it until like much later, say like 4:30 in the afternoon, and then you wasted a whole day of the scan not being done, and the patient might be nail by mouth just for the scan, and they're anxious, and it's just not pleasant for the patient. So yeah, and being polite does not hurt as well when you're requesting scans. So say please, say thank you. So just niche stuff with CT, do you want the CT with contrast or without contrast? How's their renal function? Are they on metformin? Should that be withheld? If they've got like end-stage renal disease, already on hemodialysis, does it matter if they've got contrast or not? Like, they're already on dialysis, so just give them the contrast because they're going to go for dialysis anyway. Or do you think this needs discussion with radiologists? Could they advise on a better imaging form? And in terms of MRI, some pacemakers are compatible with MRI, especially the more recent ones. But if you don't know, check with the pacemaker technicians. And once you've done that, reiterate on your request form that you've checked this. The pacemaker people said this is okay. And after and then with regards to hip replacements, should be okay after 6 weeks post-op. But yeah, just double check with the orthopedic surgeon, and then yes, again, reiterate on the form that you've checked this with the relevant people. And after you request scans, it's good practice to ring the departments to say, look, I've requested this. Have you got a specific time for this patient? Has this request been vetted? Do I need to speak to the radiologist to convince them that this patient needs the scan? Blah, blah, blah. Right. So this slide, these are my mistakes that I'm not proud of, but I think you can learn from my mistakes. So the ones in green in boxes are the ones that I've put in my request form. The ones in red are the ones that I should have put, or I should have, or like I've had to discuss with the duty radiologist. I'm not going to go through them now, but just to let you know, for patient 1, that scan did not get cancelled, but it got threatened to be cancelled at 4:30 in the afternoon. So I had to go down and speak to the duty radiologist to explain why I needed the scan. Patient 2 actually had the scan, but it turned out to be not the exact scan that we were wanting. Patient 3, the scan actually got cancelled, so I had to re-request the scan with some more information on the request form. So yeah, learn from my mistakes. So yeah, what happens after the ward round? By this time, you would have a list of jobs that you need to do. So you can organize the list of jobs by ward, or you can organize the list of jobs by the types of jobs, whether it's discharge summaries / CTOs, or imaging to request or to chase, or prescription, or any procedures like to take bloods or to do cannulas, or any discussions that you need to have, or no referrals. So you can organize that by the types of jobs, or you can also organize your jobs by the urgency of the jobs. I tend to organize mine by the wards because that works best for me. I don't know what works best for you. So yeah, you need to find out what works best for you. And after that, you need to delegate jobs among the members of the team. And it's important, once you've delegated jobs, it's important to know who is doing what and update each other regularly on whether that job has been done or not. Because sometimes, let's say, oh, I'm going to do this cannula, I'm going to try to pop this cannula in this patient. I've tried 5 times and I have failed for all 5 times. Can someone else give it a try, please? Rather than not telling anyone, and then you realize later on during the day that the patient still has not got a cannula and has missed 2 doses of antibiotics. That will compromise the patient's care, right? You need to prioritize so usually you finish ward round by 12 in the afternoon, or 1:30 in the afternoon if you're on care of the elderly. So yeah, you need to prioritize. Can this job be done after lunch, or should I do the jobs now? So I tend to do bloods right after because they take time for the blood results to come back. Cannulas, I tend to do them straight after the ward round. Urgent referrals, I tend to do them straight after because I want to speak to another specialty before the end of the day so that they can potentially review the patient on the same day rather than wait another day. Right. And also you need to know where your seniors disappear, especially if you're on a surgical rotation. After ward round, they just go straight to theatre. There's just nowhere to be found. So you need to know where you can find them. Will they be in theatre or will they be in ED, seeing referrals? Know how to contact them, know the bleep numbers. Sometimes they prefer to be contacted via phone. So yeah, just get to know them, know how to get to them really. And try to update the list so that the next morning you can just print out an updated version of the list. And don't forget to touch base with your seniors if any problems arise. I try to touch base with my seniors about 4:30 in the afternoon or earlier if I've got anything urgent or any updates. Sometimes I've got a patient that turns out to be in like full-blown obstruction from the CT scan, and then I need to find the consultant and they're in theatre, so I'd have to go down to theatre and tell them, look, this patient's got obstruction, please, what do I do? Yeah, things like that. And sometimes there are things that you need to hand over to the on-call team. So like, bloods to chase or any imaging to chase, and anything urgent to chase, hand over to the on-call team. And I think it's good practice to also let the on-call team know what to expect. Are you expecting the bloods to be very deranged, or are you not expecting anything? Like, give them a bit of a heads up. Oh, if the CRP goes up, you might want to change antibiotics to this, or if this happens, this is the plan, or if this happens, this is the plan, or whatever. Do you know what I mean? It's nice to give them a bit of a heads up. Yeah. So yeah, I've included some referral cheat sheets when you want to refer to other specialties. But yeah, that's all for me for now. I hope that was useful. Thank you very much.
All right, thank you, Shaira. Okay, because we are running out late, I'm gonna pass it straight to Dr. Fariha. If you're in here, there you go. All right, please step and kick off whenever you're ready.
Okay. Right, so I'm just gonna kick off. How do I? All right.
Fariha, have you turned on your mic? Sorry, I'm just checking. We can't hear you.
Hear me now?
Okay, cool.
Okay.
There you go. All right, cool.
Okay, right. So I'm just gonna turn back to the first slide. So basically, I'm doing the second part of outline of a typical day of an F1. Just a bit of introduction. My name is Fariha Reza. I'm one of the F1 in Belfast, Northern Ireland, and graduated from Leicester. Right. So I'm just gonna pick up from where Shaira has left. So I'm just gonna do the rest of the day of an F1. So I'm gonna be talking about things to do before going home, tips for nights and on call, useful apps, and this is very handy if you have it all on your phone, and also general tips in surviving F1. Right, so I can't seem to, sorry. Right, so this is things to do before going home. So as explained by Dr. Maliha earlier, the time that we normally be able to get away is usually 5 o'clock or 5:30 or 6 the most. Don't try to stay beyond your limit, because you have to know that as an F1, you have the right to leave on time, and you don't have to stay until 10 o'clock or anything, because there'll be an on-call team who will cover you after you left. So before I go home, what I normally do is, firstly, I will check my job list, and I'm just gonna make sure that I finish off everything, and check whether I've requested all the scans, because you don't want to leave the day with some scan being unrequested, because that will have a domino effect on the patient's discharge. Consultants might be questioning you, why don't you request yesterday? And even patient safety, that's the most important actually, patient safety, because some patients might have to have an urgent scan, and if you don't request it, that will have a big and dangerous pandem. So just finish off everything as much as you can. And then the second thing is about blood. So with regards to blood results, everything is in my hospital, at least everything is online. So the blood comes through the system. So what you have to do is basically what I normally do is before lunchtime or about like 1 or 1:30, I will go to the laptop and then go through my patient list and check everyone's blood if they are back. And then just have a glance at it. You don't have to be too specific on the numbers, but just make sure that you don't miss anything important. It's very actually easy to pick up the wrong things because they will appear as red in color. Also, they will show a warning sign. So it's very easy to just pick up, okay, so this patient has a potassium of 5.5 nearing high. So you just have to be careful about it. So yeah, just make sure that before you leave today, just make sure that you chase all blood results because you might miss a potassium of 6.5 and you don't want to leave the patients untreated. Also, with regards to forms, so as Shahira has said earlier, in her hospital, all the blood forms, because some hospitals have a paper blood forms, but in my hospital, you have to print it. It depends on which hospital or trust you are in, but just make sure that you have the forms for tomorrow for the phlebotomists. Because in the UK and Ireland, we have phlebotomists who will be taking the bloods from the patients in the morning. Usually they come around 7 or 8 or 9, depends on how busy they are. But they will come and do their rounds from wards to wards, and they will just do the bloods that have the forms in the blood book. No forms means no bloods taken. So you don't want that to happen for the next day because the consultant might want to know what's the blood results by 12 o'clock. So if you can get all the forms ready for tomorrow, you'll be all covered for the bloods for tomorrow. But as Shahira has said, she also bring some additional blood forms. So yes, that can happen as well because some patients will be admitted like 10 o'clock in the morning during the ward round. So, and you and your consultant will just go straight away. So bring your blood forms with you and then you can just fill in there and then send it to the phlebotomist. Or you can do it yourself. Right. And then the third thing is about warfarin and IV fluids. I would really like to stress on this because the main reason why we are the one who are doing it because we know the patients and this is mainly for patient safety. When we know the patients, we know the usual dose of what the patient is usually taking, and you will like go through the INR results and then look at the trend and then you prescribe it. The normal administration time for warfarin is about 6 o'clock in the evening, or it could also be 10 o'clock at night. It depends on which ward, I think. Like in cardiology ward, when I first work, they normally give warfarin at 6 p.m. So you have to make sure that all warfarin and all INR is back before at least 4 so that you can prescribe the warfarin. And then IV fluids. I would like to share a very important lesson for me about IV fluids. This happened during my first placement in cardiology, my first month, and I was on night. So in the middle of the night, I was called by a nurse to review a patient, and they were asking to review to know whether this patient still needs IV fluids overnight or not. Bear in mind, this is not my patient. This is not the ward I normally work in. I don't know nothing about this patient. So I went through the patient notes, and then the only thing that I can grasp on the notes is that IV fluids, continue IV fluids, continue IV fluids. And it doesn't say continue IV fluids overnight or continue just until 6 p.m. or anything. So it's very unclear from that. So I did a mistake. Yes, I went to assess the fluid status of the patient, but I wasn't really convinced. I think because it was my first rotation, my first month of working, I didn't have that much experience. So I just went on to give the IV fluids. Turns out at 7 o'clock, the same nurse called me saying that this patient has started to develop shortness of breath. And I was just like, I think I know what's going on. So I went there, checked the patient. She actually has pulmonary edema. So we sent her for a bedside chest X-ray, and the fluids in her lung was fluid overload. So I quickly contacted my senior, and he said, "Don't worry, just give furosemide." And yes, it got resolved in the morning. But that was a big lesson for me, not to just go by the patient notes. Even if you don't know, just challenge it. And for us as the F1 in the team, make sure you jot down, not for IV fluids overnight. Or if yes, IV fluids until like for 6 hours and then stop, something like that, something that is clear to the on-call team, right? So that is about it. And then the next thing is about handover. So Dr. Maliha and Dr. Shaira has talked a lot about handover. I think I don't have to go through it again. Basically, just hand over to the on-call team. And make sure when you hand over, you have the name and the NHS number of the patient. And then you tell them what you expect them to do. Because it can be quite frustrating on the other end to be like receiving information and you don't know what are expected from you. You'll be like, okay, so what should I do next? Like you have to make it clear to the patient that you are hand over to, that you want them to chase something or you want them to do the bloods again at 7 p.m. just to make sure the potassium is coming down, or do chest x-ray if this patient develop a new shortness of breath or something like that. Just make it clear to the patient. All right. Next bit is, okay, so if it's before weekend, just make sure that there's plan in place for the weekend in the patient notes, because as I said, you are the one who knows your patients more than the on-call team, because sometimes, like most of the time, the on-call teams are not the one who are covering your ward on a normal day. So you have to put a plan in place. If you notice that there's no plan in the notes, just ask the registrar and consultant, what do you think we should put in the notes, just to notify the weekend team. So things that you have to jot down is things like, okay, monitor AKI over the weekend, or if the SARS drop below 90 to escalate straight away or something like that, because the usual team knows them more than the on-call team. So you kind of like help the weekend team for patient safety. Okay. And then about discharges. Okay, so this is like maybe the bread and butter of being at fund. So you do a lot of secretary jobs, especially discharges. And the best time I would advise when to do discharges is, when somebody is being admitted, it's best to just start the discharges straight away on the system, because it can be saved and then edited for later. So when somebody come in, you just prep the discharge. You don't have to fill the history bit, because you don't know yet what's going to happen in this admission, but just prepare all the presenting complaint, past medical history, any relevant referral from before or something like that. And then you can complete the clinical bit when they are about to be discharged. This will save a lot of time, and if you do this before weekend, your weekend team will thank you, because you just saved them a lot of time. Also, if they are not for discharge, make sure write it clearly in the notes, because sometimes, like Shahira mentioned earlier, there's issues of keeping patients in. Sometimes they want to be discharged only after they are being seen by the physio, and sometimes it's not that easy to get physio to come. Physio can be very busy in the hospital, so they will probably like, okay, we can come in, but the earliest we can come is Monday. So just make sure write in the notes, not for discharge until physio review, something like that. Because you don't want to be like on the Monday, the consultant will be like, where's this patient? I thought you're waiting for the physio to come and check her or something like that. So just make sure you jot it down in the notes. Also about the medications, this is what I learned like with time and experience as well. It's better because when you're on the weekend, it's very difficult to get pharmacy to dispense medicines as quick as you want it to be, because they are only open for, like me in Belfast, one pharmacy is going to dispense the medications for 2 hospitals, Royal Victoria and Belfast City Hospital, but not on a normal working day, because on a normal working day we have our specific pharmacy, but on a weekend we only have one pharmacy covering for both hospitals. It's very difficult to get medicines early, and that can delay discharge on the weekend. So we don't want that to happen, because we run the bed. The bed manager will come and chase you. Why is this patient not being discharged yet? So if possible, order meds early on that Friday, or yes, Friday is the earliest that you can do actually. So just order medications and bring your the medications list to the pharmacist on the ward, and they will help you out on how to order things. But things are different in different ward and trust, so it all depends which hospital you're going to be. Right, so the next bit is about
Sorry, I'm so sorry. 2 minutes to go. I was just letting you know. I'm
Right,
sorry.
so, right, I'm just not gonna go too details in this. This is basically the tips of doing your night. During dinner, stay hydrated. Make sure you take small breaks because things can be quite exhausted. So you just take small breaks for you, and don't be afraid to ask to the seniors. Right, so these are the things to revise before you start your F1. Useful apps. Okay, so I would like to stress on this because these are the things that I wish I know before I started my F1. There's actually a lot of useful apps on Google Play and Apple Store that you can actually have on your phone, and it can be quite handy for you to go through your own call. It can be really helpful, especially if I can mention there's Pocket Doctor and ABC Medical Notes. So these are both very useful for on calls. They have like the list of things that you can do when you are being called to say chest pain. So they will provide you steps by steps what you have to ask, what you have to check, and what you have to do in that situation. And then the rest of the things are, so if I can just mention the apps that I think is a must for you to download is Induction, Microgrid, PNF, and NICE, because they're all guidelines. Okay. The next thing is general tips in surviving F1. So this is my favorite bit actually, but we're running out of time, so I'm just going to go through very quickly. So being in F1, it can be very overwhelming for you, especially on a first day. But believe me, it will get better with time. And just make sure you have friends that you can go to, or if you are married, you can always talk to your spouse after your day. Just vent out about your day because you need somebody to listen to you. And then also know your team and make sure you know your consultant as well. Make sure you try hard to learn their names on the first day or on the first week, because it makes it easier for you to ask for help or to refer to someone when you're referring to something to do. And also familiarize yourself with trust protocols. We have microgrid and also intranet, which is the internet in the trust desktops. Also be helpful because things will come back to you. People will help you again. And then be proactive. Don't be shy to ask. Also be proactive in terms of if you think the consultants or registrar might be missing something on the work round, you are the one who they are relying to ask. Don't we have to do this? Don't you think we should do this as well? Just be proactive and challenge them. Don't be shy only because you're an F1, because you are actually a fresh graduate and you probably remember most of the medical things more than they are. So just ask and challenge them if you can. Also be ready to learn. There's a lot to learn in F1, and I think you can't expect yourself to know everything on day one. That's very hard, and that's being very harsh on yourself as well. Just have a moderate expectation, because if you have a high expectation, you might be feeling down after the day, like why haven't I done that? Why this and why that? So just put a moderate expectation and keep telling yourself you are learning and you're going to be a good F1 by the end of the year. Also be kind to yourself. In the sense that if you have normal hobbies, just carry on the normal hobbies. Don't be like, okay, I don't have time to do other things because I'm so busy. I think that that shouldn't happen, because you will have time to do hobbies that you like on the weekend or things like that. Also, if I can add one more thing, which I didn't put in the slides, just look confident. I learned this from my medical school. Whenever you are in the ward, just look as if you are a confident person, even if when you don't. Because when you put like a doubt face or something, they will not believe you 100% as well, because why will I trust this person when he's not trusting herself? So just put on a very confident face, just pretend that you know everything. Although when you don't, you just like check with your seniors afterwards, or check on your app afterwards. But on the first encounter, just look confident. I think that will help you as well in the end of the day. The last thing is believe in the process. So being an F1 is a steep learning curve, very, very steep learning curve. from being a medical student to being a houseman, it's a big jump. But just believe in the process. You're not going to be excellent on the day one, but you will be with time and experience. So that's it from me. Assalamualaikum.
All right. Thank you so much, Dr. Fariha. That have been really useful. I think both of the doctors has given quite immense experience. Again, I think just to note, whatever they've said is basically what their personal experience is. So might not work for you, might work for you. So it's more of just telling you a story about how a typical day works. So different hospital work different ways, different rotations work different ways as well. So it's more of adapting that general framework whenever you have to. So don't take it hard. A to Z, whatever they said. You just kind of like I've said, adapt to whatever situation you're in. Right. Without further ado, we are quite running late with our time. I'm so sorry. I don't want to rush things, but hopefully we can go straight to our session. Next session, that'll be our breakout session. So again, as I said, kindly remind to whoever is not sure whether they're going to do foundation or internship, please DM myself or the host, Ikram UKE. If not, then we're gonna allocate it straight away. So we're gonna go straight to a different session. There'll be 2 sessions parallel at the same time. One will be more focused on the foundation program in UK, and one will be talking more of the internship program in UK. We'll talk about more, and those who are not sure whether they're gonna do PLAB or MRCP, or they don't plan to do so, you can always go for the second session, internship in UK, and we'll talk about more about like Irish Medical Council and things of how you can get housemanship there instead of UK, because it's of a total different councils, UK and Ireland. Right. We will now start allocating you to your breakout rooms. Once you will be invited to the room, just click join the breakout room, and then we're going to start the session. We're going to try and finish the session at least 5 to 4, if okay, speakers. That's the latest we can go, and then we'll proceed from there. Okay. All righty. I believe everyone's been allocated. If you have any problems, please let us know. You can always chat box, or you can turn on your mic, but I would not know who is. Just let me know what your name is, and we're going to try and put you in the breakout room.
Hello.
Hello.
Hello. Okay. I got the invitation to the Ireland internship, but I think I'm going for the foundation program for F1.
For the foundation program. All right. I'm just gonna let the host know. So just give me 1 second, so we're gonna try and allocate you.
Okay. All right. Thank you.
Yes.
Can you put Amir Jamaluddin in foundation group?
Which one again?
The foundation UK.
And what's the participant's name?
Amira Jamaluddin.
Amira Jamaluddin. Okay, I'll try. Okay, done.
Thank you.
And one more, Dr. Hafiz. That would be Zafri Zakwan.
Zafri Zakwan. Okay. Okay, done.
Thank you. Anyone else had problem? You can always shout out here. I'm here to help. Dr. Hafiz.
Yes, ada apa lagi?
Participant to UK room, Dr. Shafiq Khalid.
Syafiq Khalid, okay.
Thank you. Anyone else with problem? You can. Dr.
Okay.
Hafiz, there's one more.
Patin Alia, ya. Okay.
One more, Fadila. Fadila's iPhone.
Fadila, okay. Yep, done.
Dr. Hafiz, I think Dr. Shafiq was asking if you can change it to co-host him.
Oh, okay.
He wants
Change.
it, but I don't know if you can. I don't know how you did it.
Oh, change Dr. Shafiq to co-host. Okay.
He can't record, I think. Hi, Fik Fakri. Oh, that's fine. Hi, Afik. Do you need help with anything?
Oh, Dr. Syafina tak ada masuk grup mana lagi?
No, I'll stay here. I'll stay here. That's fine.
Sure. Okay.
It's not a session for PLAB. It's more of if you're doing a foundation in UK, if you want to do a foundation in UK or internship in UK and Ireland. So there's a different session for it. If you let us know which one do you want to go for, then we can allocate to the right room. But we're not talking about PLAB in specific. We're talking about the foundation program.
Yes.
Farah Usman, can you put her in UK? Walaupun dah nak habis.
Okay. Farah Osman to UK, yeah. Okay.
Yeah.
Um.
Anyway, Kang, sorry. We're just doing a breakout session at the moment. We're gonna get back in mainstream in about a minute or two. So if we can wait for it.
Anyway, Khan, sorry.
Alrighty, welcome back everyone. I hope that was a useful session for you guys. I'm so sorry for the rush of the time. We'll make sure we share with you with the rest of the slides. And if there's any particular question or any general question, we'll try and cater that at the very end of the session. And inshallah, hopefully we have more future programs for that as well, if that's all right for you guys. Right, I'm gonna hand over to the next slot, our very last but not least slot, to Dr. Wafi, just to talk about work-life balance, especially when you're in UK. There's a chance for you to do that, and I'll hand it over to you, Dr. Wafi.
I cannot share my screen.
Have you clicked the share screen?
Yeah, I've clicked. It says host disabled attendee screen sharing.
Oh, it's Dr. Hafiz. 1 second. Let me try if I can do. One second. I think Dr. Hafiz is trying to sort it out.
Wafi, are you not able to share your screen?
Yeah, I should be able to now.
Okay, try again. Yeah, thank you.
Okay. Can you see my screen?
Clap. Found it. Yep, there you go.
Is it moving?
It's moving. You mean your pointers? Yes.
I mean, is the screen moving now?
Yes, it is. Yeah.
Okay, great. So, Assalamualaikum warahmatullahi wabarakatuh, and hello to everyone. So I am Dr. Adlan Wafi Ramli. I'm a rheumatology registrar, and I'm also less than full-time trainee at 60%, and I work in Manchester in the UK. I'll talk briefly about LTFT in a bit, but let's move on to work-life balance. So firstly, I'm not an expert in work-life balance, but hopefully I can share some insights or tips on how we can work to strive towards achieving work-life balance. And a bit of an overview. So work-life balance, I think it's applicable to a lot of other jobs. For example, it's not just for doctors, isn't it? And especially for doctors specifically, if we're tired, we tend to make mistakes. And when we make mistakes, the consequences, unfortunately, will be impacted onto our patients. That's why it's more important than ever for us doctors to make sure that we take adequate breaks and try to have a good work-life balance. And the GMC also conducted annual surveys for the doctors in training and also trainers. And 2 years ago, they started including questions on burnout, and just to look at how much are the doctors struggling with stress in their work environment. And interestingly, about 20% of doctors feeling burnt out to a high or very high degree. In addition to that, about more than 50% always or often feel worn out at the end of the working day. And this could be to a number of things, including things like rota gaps, heavy workload, and lack of support. And it's more difficult probably for those who are just starting to work as a doctor or junior trainees if they don't get enough support, and that could lead to stress and therefore burnout. So hopefully I can share some tips on this and see if that's applicable to you. So first one, let's move on to what you can do at your workplace. So at work, try to make sure that you take time to have a break. When you take a break, make sure you eat, drink, and then try to do something else apart from anything but work. And let's say if you're doing a ward round at 9 and then you finish it early, maybe let's say 10 or 11. So if you finish all your jobs already by that time, why don't you have a coffee with your colleagues? And that'll be a good time to have a chat with them, try to get to know them, talk about anything apart from work, and try to get to know about maybe ask about their weekend plans, their holiday plans, maybe ask about their hobbies or interests. You never know, you might share some interests, and therefore you could do the same thing with your colleagues as well. And when you take a break, try to take a break away from your ward if you are based in the ward, or if you're based in an office, try to take away from the office, just so that you can take away from your usual workplace, just to give you a calmer mind, and also try to forget about work for a bit, even if just for 30 minutes. And next one, I'm going to talk about holidays. So holidays is very important. Plan early. The way I approach it is at the start of the year, I always make plans like when exactly I want to take my annual leaves. And this includes things like for Raya or Eid celebrations, birthdays, family gatherings, weddings, or if you want to go anywhere else, like traveling or something like that. And if you work in the UK, you have to give us at least 6 weeks notice. So it's important for you to plan this early so that you don't get frustrated if your leaves are being cancelled or not approved. And you don't always have to go abroad for a holiday. You can always have it around your local region or even in the same city. And even if you're staying at home, you can do something new with your family. Maybe try a new recipe, cook with your friends or family, or go to a new restaurant. And I think what the COVID-19 pandemic taught us is that you don't necessarily have to be in the same place with your loved ones. You can use technology to keep in touch with your family and friends. And there are a lot of online resources for you to learn a new skill and also to develop a new hobby. So try to use the technology that we have nowadays to make use of our time. And then the next one I'm going to talk about social network. So it is hard being a doctor, especially if you're coming here for the first time and you might be living alone. So why don't you ask these questions to yourself? Like if you're having a very tough day at university or at work, who do you want to have a chat with at the end of the day? And then ask yourself as well, whose faces do you want to see when you get back home? No man is an island. So you all need some sort of social support in our network. And for myself, I'm quite fortunate because I have my family members here. I have my wife and 2 daughters. At the same time, I also belong to a very special group, Ikram UKE. So I always have my friends as part of my social network. So just try to identify who are your social support network, and make an effort to get in touch with them. If it's your mom or your dad, if they're far away in Malaysia, try to make an effort to ring them maybe once or twice a week, or every day if you have the time. And if you don't make an effort, then that's going to be a problem. Like I have a friend who used to study in Ireland. He's a Malaysian and now he's working in Singapore, and he always tries to ring me on my WhatsApp mobile, although I don't usually answer it just because he always rings at the wrong time, like I'm on call or something. But the point is, he tries to make an effort to get in touch with me. And so I just wanted to ask all of you to make an effort to keep in touch with your friends and family, because it's important for you to have this social network of yours to give you emotional support at the end of the day. And next one. So I just listed a few aspects that I can suggest for you to find your interests, hobbies, or ambition in these 3 domains. So in terms of physical, so try to find a sport or exercise that you like to do, or maybe something to do at home, like household chores that you've always been putting off to do. Any form of physical activity, I'm sure you all know about it. It can lead to better mood, better quality of sleep, among other things. And for myself, what I enjoy to do is mowing the lawn in my garden, because at that time I can have my children running around, playing around as well. So that's another way of spending time with my family. And I also like building up or setting up IKEA furnitures with my wife, or with my eldest daughter. And again, it's another way for me to spend some quality time with my family. And sometimes you just go to IKEA, not buying anything at all, just to browse around and make plans, but we didn't end up buying anything in the end. It's just a matter of finding ways to make quality time with your family members. And next one is religious and spiritual needs. So for Muslims, we have to have our obligatory prayers 5 times a day. And for men, we also have our Jumu'ah Friday prayer. And I think when you start working, you have to make sure that, you have to be open with your colleagues, and they are very respectful as well for your religious beliefs. So you have to go for your prayers, or you have to go do your Jumu'ah prayers, just explain to them. And if you're able to do this, then I'm sure they respect you for being able to commit to your religious needs, and at the same time being a doctor as well. And I've never heard any complaints from my colleagues whenever I had to do my prayers or my Jumu'ah prayers. It's just a matter of making clear communication, and so that they're aware of your religious commitments. And for all other religions, obviously you can always perform your religious acts as long as you make sure that your colleagues are aware and what your religious needs are. And in a lot of hospitals in the UK, they have prayer or quiet room, and it's open to all people with religion or no religion at all. And I think it's important for us to find this time just to unwind, unplug from our stressful work, and then just to be in touch with ourselves, or perform our religious needs. And lastly, I would say find your passion, find something that interests you so that you can focus on the things that you like. And so the question you like to ask yourself is, how do you see yourself in 10 years? in the UK, most consultants will usually have 3 areas that they would like to focus on. And this would be medical education, research or academia, and leadership and management. And for myself, I'm interested in education and also research, which is why at the moment I'm doing one of the modules for postgraduate certificate in medical education. And next semester, I am considering to do masters in clinical rheumatology, which is also my specialty, just because I like a bit of both of this. But at the same time, it doesn't have to be medically related. You can be a writer, you can work on your business or investment, whatever it may be, or be involved in charity works. It's just a matter of finding your passion and finding your interest and try to focus on this. And having this alongside your work as a doctor helps you to achieve this work-life balance that we all have been yearning for. And last bit, I'm just going to briefly mention about LTFT. It is quite unique in the UK that we're able to do less than full-time. So there are a lot of categories, but the reason why I'm less than full-time is because I have kids. And however, there are also a number of trainees who will become LTFT because they have charity works. So we know someone, my wife and I know someone who's doing it just because they want to be a volunteer at a church. So they're doing less than full-time. And now there's a new category, category 3. You can do it just because you want to. So you don't have to have a reason for it. I think at the moment they're piloting it, but in the near future, they will expand this to all the specialties, which is a good thing for medical careers. I understand all people will be able to do LTFT because of financial reasons. Obviously, your salary will be reduced as well. And also because of visa, because if coming here as an F1, you'll be on tier 4, therefore you have to be full-time. So maybe not in F1 and F2, because I started becoming LTFT after F2. And I think that's one of the best decisions I've ever did, because I get to spend more time with my children and also my family and do other things alongside it. And so I'm really an advocate for LTFT if you can, and especially dads, they should do it so that they can spend more time with their kids. So that is all from me. And I hope you find this beneficial. And work-life balance is something that people in all specialties would like to strive for. And it's just a matter of finding the ways to do it, small step at a time. That's all for me. Assalamu alaikum.
Alaikum salam. Thank you, Dr. Wafi. Right. What's the normal working hours in less than full-time? Dr. Wafi can answer that really quick.
So for less than full-time, I'm 60%. So if a full-time is 100%, that means 5 times a day. For example, 5 times a day, that means I'll be doing 5 days a week. That means I'll be doing 3 days a week because I'm 60%. My own calls will also be 60% of the full-time. So if someone do, for example, in a year, they do 10 on calls, I'll be doing 6 on calls. That's an example. No, the actual number of on calls is obviously like 30 or 20. So it'd be percentage-wise. I know, it does sound like a dream. It only exists in the UK.
Exactly. And it's a new thing, this less than full-time. The paid will, as I think Dr. Wafi did mention about less than full-time, again, if it's 60%, therefore your pay will be about 60%. So I've just included in the chat box for someone who wants to know more information on less than full-time. There's so many things in terms of the categories, like what Dr. Wafi mentioned, of when you decided to do less than full-time. Like Dr. Wafi said, if you don't even have any reason, go for it. You can always opt for it anyways, because sometimes people do love to do other things besides medicine. You can always do things like that. Fine. I wouldn't vouch too much on that, because I think we're sort of running out of time. Anyways, we're gonna do Q&A session anyways. So for this session, I know we sort of running late with time, but I think this is probably one of the important session. If you need to go or leave the session, please do so. We're going to record the session anyways. But if you want to stay, please feel free, ask as much questions as you want. We'll try and aim about 7 minutes, if that's possible. If that ever possible, it will be possible, inshallah. If it's not answerable, we'll answer it through your. We'll make a separate Q&A, as in like a document of Q&As, so whatever that you've asked, and we're going to try and answer that with our experienced doctors in the session at the moment. Okay. Right, I'm gonna try If you wanna put in the chat box whatever questions you have, feel free to do so, and then we can try get some of the doctor's answers as well. Whoopee. Where is my Zoom? I can't even open this. Right. There's a question. Wanted to ask in terms of training opportunity wise for international grads, would we be given the same opportunities as for those who grad locally, UK? I suppose that's what the main concern of heading over to UK. Shall I leave it to Farah? Farah, you want to answer that? Sorry, strategy allocating. If you can answer that or have any answer to that.
Sorry, I just realized I was I muted myself. Can you rephrase the question again?
So I think the concern for the international graduates or Malaysian grads mostly in there, their concern is if say what's the opportunity training opportunities for those who are international graduates as opposed to compared to the locals at the moment. This will play around with the visa, I believe, but I'll leave it to you.
Okay, I'm not entirely sure if I'm the best person to answer this because even though I'm an international doctor, but I'm a local graduate, so I'm not too sure if I can share the same kind of like anxieties or concerns about this really, because I think I have quite a bit more advantage in terms of knowing the system a bit more because I'm a bit more aware of the system. So I think as an international medical graduate, and if it's your first time coming to the UK or Ireland and just familiarizing yourself, you might need to take a bit more time to just adjust yourself. But you know, in terms of the application, the specialty application, you should be just at the same path. They're not going to discredit you just because you're an you're an overseas graduate. As long as you can prove that you've done this, the amount of work that deserves you to get into that specialty application, inshallah, I don't really see the reason why not to. And I think this is also one of the reasons why we're starting to create that ICRAM health and well-being cluster. And yes, I understand that it's a faith-based organization, but we're open to everyone, and we have quite a lot of connections with like the Malaysian community, Malaysian medical graduates as well. So if you need some, added support, buddy system mentorship, if you want to sink into your new workplace, and having like a first-hand experience from any of us, feel free to, subscribe to our channel and just like email us if you have anything personal to ask. And inshallah, we can guide you from there. I personally know it can be a little bit difficult when I came first as a medical student because I'm new graduate, so I come like halfway through the training and I don't really know anyone. So having to build your network from scratch can be a little bit more difficult. But inshallah, if you show good work ethics and exhibit good attitude at work, positive attitude at work, you're well liked by your colleagues, very easy for you to build your network, get into projects, build your portfolio, and inshallah stand at quite an employable status to get into even competitive specialties, inshallah.
All
I hope
right,
that answers it. I don't know.
I think we'll include again for everyone. We will again. I think we're going to reiterate this in a document form. I think it's much more better because I don't think we can manage to answer every question, but we'll try. We'll try as much as we can. Okay. For the second question, where was it? I think someone questioned for Dr. Farah again. I didn't numbers of research or audit that you did to get into CS training. I would stop there just because. For Syed Ziman, we are gonna have a specialty training program session by itself. So if say we did this last year. So for those who wants to apply for a job specialty training wise, so we're gonna try and indicate that because some people might not do surgery. So I'm not gonna answer that in full later on. Farah might answer that for you.
I'm sorry, just on that, Ziman, if you want to go to the YouTube page, ICRAM Health and Wellbeing YouTube page, there is one dedicated video just for course surgical trainee application. So if you want to go through that, I think that will answer it more than everything, but also reply to you privately. So just to let you know. Okay, carry on, Peanut.
Fabulous. Okay. Next question, just a quick one. For those who wants to go for a job in UK starting as an F2, most of the time you're going to start as an standalone. I just had a bit of experience, so I'm going to answer that straight. The question was, how about if someone who wants to do a job training, first job at UK, and what's the e-portfolio? Is it the same as FY2? Yep. If you are doing FY1 or FY2, you're going to use the same portfolio. Horace, standalone or standalone, you're going to use the same portfolio because you're going to have same requirements for you to go into either transcript training or whatever specialty training you're going to go for. That will be told when you apply for that foundation program. They will tell you what kind of portfolios you'll be using. So all foundation year trainees, except for locum trainees, you're going to use the same portfolio. Horace. Right. Who is that? Now I was asking a question regarding pathway to island without PLAB. For formulations, I think that would be more to Dr. Shafiq, if that's okay.
Yeah. My session just now, it was recorded. Okay, so you can wait until the formal recording lah. But just for a bit of an overview, in order to obtain Irish Medical Council and subsequently possibly getting onto the Irish medical training system, if you have completed a 2-year HO-ship in Malaysia, that is recognized as equivalent to an Irish training, an Irish internship training. So Irish Medical Council will give you registration upon completion of the 2 years of HO-ship. You don't have to do exam, you don't have to do PLAB, you don't have to do MRCP. No, you can come here and you can do the more advanced exams. You can do the MRCPI, you can do the MRCP UK upon coming to Ireland after you finish your 2-year HO-ship. So it's a bit lucrative because you don't have to spend a lot of money doing like PLAB. You don't have to study biochemistry or Krebs cycle or whatever it is again, if you are considering a career in Ireland. So if you are a Malaysian graduate, for example, if you finish your 2-year HO-ship, then you can then you can then come to work to Ireland. So any questions, you can email me.
Fabulous. Thank you, Dr. Shafiq. Right, I'm gonna proceed with the next question, which is from Sarah. Sarah said, for foundation program for international doctors, is it specialty based or we're going to be allocated to different posting for specific period, like internal medicine, surgery, peds, and ONG? I'll answer that for you, just because I'm in a FY2 at the moment. So basically for that, for those who's going to start FY1 or FY2, you're going to be allocated just random postings unless you are being given the option to choose your postings. So compared to Malaysia, where you have to do 6 compulsory postings, as what you guys know already, the only compulsory ones in UK is one internal medicine posting. Could be gastro, could be anything, could be anything in internal medicine, not necessarily just internal medicine. And one surgical posting, that's it. And the others, you can do whatever you want. You can do radiology, you can decide you want to do public health, you want to do whatever, basically. This is again, it will change from time to time, I would say, for foundation program, because 2 years back, the foundation program is more, so I think the question probably applies to someone who asked the first question just now, because the local graduates has been allocated to jobs or being given the option to actually choose their jobs initially, and whatever the remaining posts will be given to the international graduates. This time around, they change around a lot. There's a lot of changes. Whether you guys have the same opportunity or not, they might change that from time to time. So I would suggest go to foundation program website. They always update stuff about this there. So they could change, they might just change for the next year, for those who's going to do foundation program next year, they might change the system again. So always have an update that they always update stuff there anyways. So please have a look. And it's not, like I said, it's not 6 compulsory posts. It's 6 compulsory postings, but not necessarily the 6 like ONG, PEDS, or whatever. You could just anything. You could have 2 surgical postings. You might do a medical and whatnot. Yes. Any more questions besides that? Let me have a look. I can't see any new questions unless someone wants to turn on their audio and want to ask other question. Maybe if I could recommend. Of course you can. Of course you can. I think Dr. Medical Training, medical training, we'll take note about that, inshallah, for your question there. Thank you, Amiruddin, for the suggestion. Any other questions before I close the session? Yes, if you're talking about foundation training, yes. Psychiatry. Sorry, the question is, how about psych posting? Is it available at all trusts? All trusts? Okay, all trusts is a bit difficult. Nationally, yes. Nationally, yes. Some trusts might not offer psychiatry postings. But again, like I've said, it changes from time to time. They might change whether you can pick your postings or they just allocate you with things, because international graduates are a bit, their process is a bit different from the local graduates, because normally local graduates are being offered the jobs first before the international graduates, if that makes sense. Of course, yes, we're gonna that's what Afiq. Yes, we're gonna share you the emails later on, inshallah, with the feedback forms, so you can ask questions specifically to them as well. Any more? Calling once, twice, or third time? No more questions? All right, thank you so much, everyone, for the wonderful session. I think would like to thank all the speakers, to all of speakers who have given quite extensive and comprehensive session. It might seem a bit rushing when you have 2 hours, but I hope that it's been useful for you guys. And please we invite more questions as well. You can always email us directly, and we'll see how it goes from there. I'm just going to share my slide for a bit, really quick. Right. Okay. So I think later on our admin will send a feedback form, including the speakers' emails. And please have your feedback. We will be really grateful for more feedbacks, because that's the only way we can improve the quality of our programs. Whether it's too quick, whether you want like someone said about recommendation and suggestion of different programs. And please kindly appreciate your feedback, and have to do so. For those who have iPhone, you probably can just kind of like point it out to the QR code and you can get straight to your feedback form. And I'm going to go straight to the next slide. That will be right. And I'm just going to kind of tell you a bit more of our upcoming sessions. Like I've said, that's a Dear Doctor. When I say another Dear Doctor online web series, we have lots of web series. If you go to YouTube and subscribe to our Ikram Health and Wellbeing cluster, there's lots of videos under Dear Doctor series. And this is more for our upcoming sessions. So we're going to talk about CV and portfolio workshops. I think question about like interview skills for specialty training jobs application. This is probably for those who want specifically say, I want to go into anesthetics training job. How can I enhance my portfolio for me to get into the training job? So inshallah, this is something that we're gonna do. We had done it before last year, and hopefully we'll do it again this year. All right. And if you want to know more about us, you can. This is just a generic Ikram UK. As I said, that's the main big organization, the non-governmental organization, Ikram UKE. And under Ikram UKE, we have lots of clusters, and one of it is health and well-being clusters. So we, if you have anything, you can always direct your questions to us. And hopefully, please follow us in the page, and we normally update stuff almost on a daily basis or weekly basis on things. Especially if you want, especially for dear doctors or doctors, that will be for the Ikram and health and well-being cluster, inshallah. I think without further ado, that's about it for today. Thank you so much, everyone, for joining our program. We would like to see you again later in future, hopefully, inshallah. Please come and visit us, follow us, subscribe to our YouTube channel, and hopefully see you again for the next session. All right, we're just gonna close session for the Muslims. We're gonna just close the session with Surah Al-As, and inshallah, that'll be the end for today. All right, thank you, everyone. Assalamu alaikum warahmatullahi wabarakatuh.